Pediatric Ophthalmology. I'm honored to invite Dr. Pawan Shrestha, who is a consultant pediatric ophthalmologist, a respected expert in this field, who will be speaking on a topic, tackling the growing eye, key consideration in pediatric cataract surgery. Please join me in welcoming Dr. Pawan Shrestha to the stage.
Good afternoon, everyone. So I'll be talking on key considerations in pediatric cataract surgery, how to tackle a growing eye. As we know that the eye of a child is still growing unlike an adult eye. So there's a phase of rapid growth. Rapid growth in less than 2 years, and by the age of 3 years, about 80 to 90% of the growth is the dimension of the adult eye is achieved. So there are always dilemma on whether to do surgery or not, which are implants or regarding which IOL can be placed as well. So surgical intervention should be done early and should be done and it should be done in visually significant cataract. So what does visually significant in children mean? If you can't see the fundus of the child, then it's a visually significant cataract. So if there are any spring, nystagmus, or if the vision is less than 6 mm, then you have to intervene in these children. So timing of the surgery, as I said, should be done early as possible. It should be, if it is unilateral, then it should be between 4 to 6 weeks. If it is bilateral, 6 to 8 weeks. And the second eye should be done as early as 1 week. But you can't go beyond 2 weeks of the first surgery. So these are the biometric formulae. So none of these are accurate, where predicted errors range from 0.7 diopters to 1.32 diopters. So what we do is, if the axial length is less than 20 millimeter, then we go for ophthalmic. And if the axial length is more than 22, then we go for SRKT. So now, in exciting times, we have IOL-based, artificial intelligence-based IOL calculation, where predictive errors are being reduced. So our power reduction, be careful with our power reduction in unilateral cases, because even one diopter of anisommetria is a stimulus for amblyopia. And if it is more than 3 diopters, then there is a chances of anisoconia, and brain won't handle more than 5% of anisoconia if there is image disparity of more than 5%. So this is what we do in our setting, and you need to be careful which type of population you are treating, whether the parents can afford contact lenses or not. So when you implant the IOL, in less than 6 months, you are not supposed to implant the IOL because there are chances of complication. In more than 6 months, 2 years, or more than 2 years, implant IOL, but the eye should accommodate the IOL you are implanting. So if the axial length is more than 80, if the AC depth is more than 2.5, and white to white is more than 10, then only you can implant the IOL. So if you don't, if there is a mismatch in size of the IOL, then there are complications like disinfection, UGS disruption, iris trapping, and all these. So there are various types of IOL designs. What is preferred in children is rigid, 3-piece foldable lenses, and if it is more than, the child is more than 2 years, then you can use flexible single-piece adult IOL as well. If the child is non-affording, then rigid PMMA can be placed in the bag or in the cervix. So when you are implanting a foreign body, just be careful and be wary of its biocompatibility. It just says it's simply the foreign body reaction to the material you are going to implant. So if there are 2 types of biocompatibility that you need to consider: uveal and capsular biocompatibility. So hydrophobic PMMA is more biocompatible to the uveal tissue, where the capsular bag is more biocompatible to the hydrophobic acrylic lenses. So site of implantation should always be in the IOL bag. not the sulcus. And SFIL should be, I do SFIL in more than 7 years children because anterior surgery conditions have stabilized, sclera is thicker and more resistant. Minimum reduction of IL power is there. So children will be cooperative in pre and post-op examinations for anti therapy as well. And there are less chances of complications. So sulcus placement, what I would like to highlight is that please do not place the foldable single-piece lenses in the sulcus in children, especially in children, because the center part of the lens is so thick and the sulcus dimension is so small that it's going to, the iris is going to lock on the lens, and especially if it is a square iris, it's going to lock on the lens for the whole life. So there will be iris shaping, inflammation, PAO and as well. So ideally, the haptic should be of small size so that the surface area of contact is less, and this haptic optic junction should be small so that it can be double optic capture can be done, and there should be angulation of 5 to 10 degrees. So please do not implant foldable IOL in the surface in children. So surgery, lens aspiration, PPC, no IOL in less than 6 to 7 months. Lens aspiration, PPC, AB with PCIOL in less than 6. And if the children is uncooperative, if the child has nystagmus, mentally challenged, if the child cannot sit for YAG capsulotomy, and if the child is hyperactive, then you have to do PPC AB. And PPC AB, no AB and PCI in 7 to 10. That's what I follow. And PPC, lens aspiration and PCI in 10 to 16 years child. So this is the video. It's a case of lamellar cataract. So I have, I'm creating a square tunnel. And these children should have sutures. So this tunnel is a bit behind what we do in adults. I have entered anterior chamber. So I have pricked the anterior capsule of the lens and flap in place. So I am doing the CCC. And in this lamellar cataract, you can trace the opacity. The size will be adequate if you just trace the opacity of the lens. And the vector force should be always be directed towards the center. And there should be adequate pressure in the anterior chamber, and grasping and re-grasping should be there. So lens is out, capsule in up. So this is the step where I puncture the posterior capsule. So ABC is being done. This stage, I check whether the anterior eyelid face is intact or not. So if it is not, if it is intact, then I simply place the IOL in the bag. I would dial the IOL once more because of the lens epithelial cells that will be dispersed, and it helps in PCO, reducing PCO or PO formation. So this is the stage where I do anterior vitrectomy. I do not insert the cannula.
You have 2 minutes remaining.
So I think I should switch on to the next video. So this is a case with intimacy cataract. So what I'd like to show is that that lenticular pressure is very high. I'm being cautious, and I'm pulling it towards the center. So at this stage, we don't need to do hydrodissection because at this stage, we don't know what the status of the posterior capsule is. So if there is a bony posterior capsule, if you do hydrodissection, the lens is going to drop down. So you don't need to do the hydrodissection and just aspirate at the periphery. Don't directly go towards the center of the lens because there is a positive vitreous pressure and it's going to bulge inwards. And if it gets hot, then you are going to have PCR. This is how I now see that. You need to have well-maintained area of transverse pressure for this. Now I'll be implanting lens in the AC. This is a foldable lens. And I have dialed it in the bag. So after this, I will be doing this is anti-radical being done behind the lens. This is how I adjust. Because the capsule was a bit large, so at last I removed the capsule by giving a nip on the capsule. So this is the final figure. So to conclude, cataract surgery for the really significant cataracts only. None of the IR power calculation formula I have is accurate. Think about amblyopia and aneuploidia when using the IR power. Know when to implant and when not to implant. Whatever you do with the patient stays with the child for life. So I would like to conclude with a report that spot it early, treat it right, give the child a future bright. And this is not my patient, this is AI generated